Thank you. So Alan gave me 5 minutes to address this topic. So I'm going just to show a case that maybe is the one that more difficult for us to assess and come back with a conclusion. Are those patients that have multiple medical problems that may explain the symptoms of this patient? So this one in particular is a 71-year-old female with history of treated myasthenia gravis, well treated, I say, no symptoms in that regard. History of obstructive sleep apnea and pulmonary hypertension. Her symptoms are shortness of breath and peripheral edema. And the question is if this patient is in heart failure or is just due to other problems. In terms of the physical exam, I'm just going to highlight that this patient is overweight or mildly obese, and I think this is something that we probably underestimate. So, and her BNP is just marginally elevated. So no clear cut in any of this, and the physical exam was not revealing. The EKG, not much for Dr. Kanji. She's in sinus rhythm. The PR looks a little bit short, but no documented arrhythmias in this case, and really no major issues, and heart rate seems to be well controlled. The echocardiogram, and I have only a few pictures here. I think the more relevant is the fact that the LV is normal in size, and the systolic function, as assessed by motion at least, is normal. Sorry. And the four-chamber view again, like the same, both ventricles are normal in size. And the left atrium, at least if you visually compare to the LV, looks a little bit prominent. And there is some degree of mitral regurgitation, but not seems to be very significant, maybe mild to moderate at the most. So this is the key finding in this particular patient is her mitral inflow, when you can see that she has 3 distinct waves. The E wave, the L wave, and the NA wave. And again, for this patient that is 71 and has other issues, probably this is could be considered not normal. The decel time also is short, so this is somewhat of a restrictive filling pattern. And then the annular velocities, and again, you can see there is a little bit of variability here in the velocities, so probably the right way to do would be to average. The septal velocity is 6, I mean, you could say that between 6 and 7, and the lateral wall is between maybe 9 and 10, something in that range, you know. Again, I think if you average, probably these numbers come a little bit shorter. And the global stain is normal. The TR velocity, again, is something important. This is elevated. It's calculated at 44 plus the radial pressure, probably around 3.8 or something in that range. And again, this is the truly abnormal finding. But remember, this patient has some obstructive sleep apnea. So just to summarize the finding, this is multiple medical conditions. These are the numbers of this. Of that, and the LA was only mildly enlarged if you index this patient. Now, again, I think at this point it's not very clear if this patient has SPEF. And in terms of the multiple parameters, one of the things is in patients that are obese, maybe we shouldn't index by body surface area, although this patient is not on the extremes, she's not morbidly obese. So by the all guidelines, she's marginal, maybe 2 out of that, so that should be categorized and indeterminate. And again, but I want to emphasize that this, in isolation, this is really an abnormal tracing that suggests elevated pressures. This is the more recent guidelines for the British Echo Society, and in those patients like this that is indeterminate by other mitral inflow and annular velocities, they suggest other parameters. And I think in this particular case, the atrial velocity was short. The tracing of the pulmonary veins was not very good. And again, I think this is, again, a difficult patient that we have to assess is really in heart failure or is due to other comorbidities. Thank you.